Thank you for joining us for a Collegial Conversation with Diana Clark. Joining us today is Dr. Lantie Jorandby. Dr. Jorandby is the Chief Medical Officer of Lakeview Health, a dual diagnosis and addiction treatment center located in Jacksonville, Florida. Dr. Jorandby is joining us today to discuss about women and addiction. Thank you for joining us, Dr. Jorandby. I will now pass the conversation over to Diana.
Thank you, Laura. And thank you for having me.
Oh, you're very welcome. I am really interested in the topic we selected today. For our audience, Dr. Jorandby, can I call you Lantie? It might be
Yes,
easy.
please. Yes.
Okay. Lantie has a bunch of different expertise, having developed in residential treatment programs and outside, I would imagine. But the one I really wanted to talk today about is women and addiction. And 20 years ago, more than 20 years ago, when I first started in this field, it was very apparent to me that not just the trajectory, the damage, the treatment of women in addiction was not measured by or developed by women for women. That seemed clear.
I totally agree. And I recall it's been more than 20 years for me when I was learning and training. And I remember asking a professor, someone I really respected, about the idea of women and substance use. And is there a difference between the genders? And his response was a bit dismissive. And I thought, oh, okay, well, I guess that, that was a bust. But I always had held that kernel of belief. Yep. That there has to be differences. And so one of the things that I've learned over the course of the last 20 plus years really is that women have very unique needs, and they have not been well recognized or well measured. And one of the good things about the last probably 10 years is that we have seen more studies that are looking at women as a population, women as a cohort, and what are the nuances? What are the things that we need to be aware of? How do we craft their treatment and their recovery based on those needs and those differences?
So let's just talk about the etiology of addiction for women. Do you think that it actually has a different origin point? Chemically, environmentally? I mean, we should start there.
Right. I think I definitely know it does. I've been reading some interesting recent research identifying different parts of the brain that are activated for women versus men, especially around the topic of anxiety and stress and how that interfaces with addiction. Because what we're learning about women is that they tend to use substances because they're treating a symptom or a cluster of symptoms, whether it be a trauma or trauma symptoms, whether it be stress, anxiety, or even a negative mood. So we do know that there are parts of the brain that are activated differently for women than for men in that kind of scenario. So if you look at the etiology, if you're looking at just the root of what we're talking about with substance, that's really interesting. I thought that was absolutely fascinating. And what it came out of was some studies that were done around COVID, because we know COVID has really hit everybody so hard. But from what we're seeing is women are actually harder hit, partly because they are caregivers. They're also working. Most of them are working full time. So they have all these things on their plates. And then you introduce this pandemic and all the uncertainty, and it really spiked their substance use. And so some of that research had been looking at structural changes in the brain.
So my understanding about women in addiction, some of this is myth, some of this is just hearsay, and some of this is old research. So let me see if I can ask you a few questions and you can say myth. And that is even the development of, let's use alcohol, for example. My understanding of the way women become alcoholics is different even than the way men do. Men may drink and ratchet down into disorder, whereas women seem to do this.
Yes.
Is that your experience as well?
What we have seen where I work here, and I work with just a brilliant addiction medicine doctor who she herself has done a lot of the research into this. And she and I both have observed that you're right. It's almost like they go off a cliff. It's not this kind of steady decline, and they get sicker faster. So and they need less of the substance to get addicted. So where men might be drinking X amount, women don't even need that much. They might need half that amount to really get to the point where they're in a full-blown addiction. And then, like you're saying, that kind of off the cliff thing, they have a lot of medical issues that pop up that are much more severe than what we might see in men. And I think part of it is they come to treatment late. So they've kind of delayed coming into treatment. There's a lot of barriers that women have for treatment that men don't. And so when we get them, they're much sicker than their male cohort.
So what are the barriers for women accepting treatment? That's a great.
One of the biggest ones, and we see this across the board, so it doesn't matter whether you're a man or a woman, is that difficulty acknowledging that they need help. So that alone is a huge barrier. But the unique ones for women that we see are that they are often the caregiver, whether it's for an elder parent or children or both. They're that sandwich generation that we read about. So caregiving can be a real barrier. They don't want to leave the family. They don't have childcare resources. So they don't literally have anybody who can take care of their children. And then that also kind of leads into the economics of it as well, because women still get paid less than a man. There's still a lot of income inequality related to men and women. And so they don't have the money to be able to maybe go to treatment or to be in treatment for 4 to 6 weeks or even shorter lengths. And so often those are the bigger barriers. And then another thing that really is heartbreaking is that women, if they don't have support of their partner, and it doesn't matter, it doesn't have to be a man, it could be a woman, it could be anybody, but if that partner or that really important person in their life doesn't support them going to treatment, it's often a huge reason they don't go, or a huge reason that they leave early, because they're getting the phone calls and they're getting the person at home says, listen, we need you. You can't be there. You don't have we just can't spare you. And so those are the biggies that we see.
I can imagine that for a female cohort, hearing the lack of, you go there and do your work would be a really, really interfering piece.
Absolutely. Yeah.
Most
women. And it does. Yeah. And those are the ones where we work so hard to remove all these barriers. We're trying to get FMLA filed. We're trying to help with childcare, get services in the home if it's needed. Our case managers are superheroes as far as I'm concerned with all the things they're able to do. But when it comes down to it, if you don't have that support at home, everything else just kind of it doesn't count, unfortunately.
So myth number 2, men will leave a female partner with a substance use disorder at a more frequent rate than women will leave a male spouse with a substance use disorder.
I've heard that. I don't know if I can put my fingers on the studies or the data behind that, but anecdotally, that is absolutely what we see. There's just so much. And I think you have to understand there's layers to it too. Men have a lot more financial independence. So women leaving a partner who's using or trying to separate, there's just so much more that they're struggling with that falls on them. So maybe they can't leave. They just don't have the money or the resources, or maybe they can't leave because they don't have the social support network. But I do believe that is correct. Again, please forgive me. I don't know if I can put my fingers on those numbers.
Perpetuating myth here.
Yeah.
It's okay. You're right. So the other piece of information I have heard over the years is that women suffer with organ damage quicker than men. Can you talk to us a little bit about which organs are impacted quicker in a woman than in a man?
That is absolutely true. And we're learning more about that all the time. When I looked into this way back when I started digging into all of the research behind this, it was only 2009, which is obviously about 13 years ago, but it seems like it should have been much longer ago. 2009 is really when SAMHSA, Substance Abuse and Mental Health Services Administration, which is federal government supported mental health and substance abuse services, they finally acknowledged that there are differences organically and physically for women versus men in substance use treatment or in substance use disorders. And so what the organs that are really damaged for women include the liver. They come in with a liver disease that is much more advanced than what we might see on the other side with the male population. We see a very high risk with breast cancer. So that actually is tremendously scary if you think about it. And I believe the numbers are, I want to say for every 10 grams of alcohol, your breast cancer risk goes up by several percent. So it's really remarkable. And they're even linking breast cancer risk to women that just drink one drink a day. So you've got the liver problems, you've got the breast cancer risk. You also see risks with heart disease. So most of the time, men are the owners of heart disease. You hear about men dying of heart attacks, less so for women, but it kind of helps them track up to where men are as far as those risks with heart disease, especially with alcohol. And so those are the big ones we see. And then a lot of what my understanding is the reasons behind that seem to be rooted in hormone changes. So testosterone versus estrogen and progesterone, all of those things kind of change the way the body processes alcohol. And I'm speaking about alcohol specifically, but for instance, women don't make as much of the enzyme that breaks alcohol down as men do. So that's just a deficit that's just out there. And so when you can't break it down and it's sitting in your body and it's causing damage, it really does accelerate their illnesses much more.
Very interesting. So when we think about women in treatment, I know 20 years ago, there was a lot of just separate out the women and give them the same treatment. What kinds of treatments have you seen develop in this since SAMHSA came out in 2000 that seem more helpful for women? Yeah.
One of the things that I have seen tremendously helpful is the focus on trauma. So trauma-informed care, being able to be aware and recognize trauma in that individual and then address it, because what we've learned is that women, for instance, have a much higher risk with trauma. They're more likely to be victimized by their intimate partner. They're more likely to be at risk for rape. If they're in that addictive cycle, they're more likely to be impaired and be re-victimized. So the whole trauma piece, I think, is really key. And being able, to recognize it, be aware of it, and then try to address it, because if you don't, we see them relapse pretty quickly. And where I work, for instance, at Lakeview, I would say, and I looked at the numbers in the last few months, it's about 75% of women that are coming in for treatment have some form of trauma in their life or abuse. So even as an adult or a child, and all of that really simmers there. And if you can't address it, if you can't really work at it, then they aren't going to be able to do recovery as well. So I would say that piece is really key. The other thing that I really like about what SAMHSA put together, and then there's some interesting studies and research out of Harvard. Shelley Greenfield had done some work looking at gender responsiveness. So, and that's, like you had said earlier, a lot of people thought we just separate them out and treat them the same. Well, it actually doesn't always work that well. What we're finding is that you can tailor the program, you can tailor the environment, you can tailor all of the resources that you put together for each population. So men also have unique needs. We're not talking a lot about them today, but the women's side of it, we talked about reducing the barriers, making sure their environments are safe so that they can feel like they can talk about their vulnerabilities or their traumas. Creating that physical space that really fosters community and social interaction, because women often isolate when they're in addiction and even in treatment. So all of those things we're learning are nice ways to add layers to treatment for each population.
That's great. Can we talk about oxytocin for a minute?
Oh, sure.
I am fascinated. So this is my own personal plug for doing a little bit more exploration. My understanding is as oxytocin elevates, cortisol, stress hormones, reduce. We're not trying to get everybody to be in treatment, getting oxytocin through sexual activity, but there's got to be ways of less.
Right. How to stimulate that in a more natural way. I agree. Well, sexual, intercourse, of course, is very natural, but like you don't want them to have it in treatment.
No.
I agree. I've read some interesting studies where they were working at intranasal. I want to say it was intranasal oxytocin. And I had a doctor colleague of mine that was looking at that specifically, and I haven't really followed up with her on that, but there's a lot of interesting data behind it because like you said, the cortisol levels go down. People have that sense of safety, and the emotional bonding is very strong. And I absolutely think that's a great resource that we probably need to do more research on, and maybe somehow figure out how to create a reasonable vehicle to deliver it. And I had to tell you, I don't know enough about that right now to speak.
I don't know enough about it, but when I think about that one fact that cortisol gets reduced, and if women are there in part as responses to anxiety and trauma, where they don't have access to oxytocin, where they don't have that sense of connection and belonging anymore, then it would make sense, even if we're using behavioral changes to elevate connection.
It could be a cement of sorts. I agree. I think that's a pretty cool idea.
There we go. Well, I'm gonna hold you to it then, and we're gonna talk in a year and see what's going on.
Either of us have created it in our labs.
That's right. That is right.
Yeah.
I had run a women's group at one point, and one of the goals of the group was to elevate oxytocin naturally without
really cool.
touch.
Yeah.
And it was really interesting. Group singing elevates oxytocin.
Wow, I didn't know that.
Right? Endorphins and oxytocin. Random acts of kindness elevate oxytocin.
I've read about that. That's really cool. So you could almost have an oxytocin group just to target ideas and ways to really increase that. That is really neat. Now you're challenging me. I'm going to dig into that.
Good. Anything, if you were to go back in time and tell the you 20 years ago, what would be something that you would encourage yourself to be or learn?
Oh, wow. You know what? There were a lot of things I wanted to do, and I still have on my list. I've always been fascinated by the brain. So if I could go back, I might actually be a neurosurgeon. I feel like oh, really?
Not a neurosurgeon, but a neuroscientist, certainly.
Yeah. I love neuroscience and just the different parts of the brain we're learning about and how they interconnect and the differences between individuals. It's fascinating. I just love that. So I'd probably do that. And a ballerina. I'd be a ballerina.
There you go. You could be operating and twirling all of this in the operating room.
Right, exactly.
Well, thank you for a really pleasant half an hour. I loved
that went fast.
And please continue your quest to learn more, deliver better, and hold that compassion for women coming into treatment. Thank you.
Thank you so much for having me, Diana. I really have enjoyed it.